Hey guys, today we are going to present Module 6 for you, which discusses addressing relapse and addiction counseling. So relapse is one of the most challenging and common experiences in substance use treatment, and it's also one of the most important skills for counselors to learn how to manage effectively. This section focuses on understanding relapse, recognizing triggers, and responding to relapse in a way that supports recovery rather than discouraging it. So now that we have introduced our topic, we will start by defining what relapse actually is and how it is understood in addiction counseling. Relapse is usually defined as a return to substance use after a period of sobriety. The reading explains that relapse can be viewed in two ways, either as a momentary act of using or as a full return to ongoing substance use. Regardless of how it's defined, relapse is common during recovery and treatment. As counselors, it's important for us to understand that relapse is not rare or unexpected. It's often part of the recovery process, and how we respond to it can significantly impact whether a client continues treatment or disengages.
So understanding the definition is important, but there are also a lot of misconceptions about relapse. So next, we're going to look at some common myths and facts that challenge them. Myth number 1 is relapse is often misunderstood as intentional behavior. The fact is, in reality, it is typically a stress-driven response influenced by neurobiology and environmental triggers. Myth number 2, a setback does not erase prior treatment gains. Fact, it can instead highlight areas where coping skills and supports need strengthening. Myth number 3, relapse should not be interpreted as lack of commitment. The truth is, because addiction affects the brain functioning, reoccurrence can occur even when motivation remains strong. Once we understand what a relapse is and what it is not, the next step is looking at how counselors should respond when relapse happens. When a relapse occurs, the counselor's first role is to assess what happened and why. This includes exploring relapse history, identifying patterns, and understanding cognitive and emotional factors involved. We also review treatment history to determine what strategies were more effective and where gaps may exist. It's important to assess craving levels, environmental triggers, and support systems. The goal is not to assign blame, but to gather information so the treatment plan can be adjusted in a meaningful way.
Yeah, so a big part of responding to relapse is identifying what led up to it. So that brings us to the different types of relapse triggers. The reading emphasizes that relapse triggers are not limited to direct exposure to substances. Triggers can be external, such as movies, music, videos, certain days of the week, or even receiving a paycheck. These cues can activate learned associations in the brain. Triggers can also be internal, such as stress, mood, instability, sensation-seeking behavior, or lack of coping skills. Environmental instability, relationships, conflict, and co-occurring disorders can further increase vulnerability. Understanding these categories help counselors identify what may have contributed to relapse beyond simply the presence of drugs. So after identifying triggers, the counselor's response becomes critical. So now we will discuss best practice for treating relapse in a way that supports the individual's recovery. After a relapse, the counselor's response is critical. Clients are often experiencing shame, guilt, or embarrassment, so responding with empathy is essential. The reading cautions against scare tactics, extreme statements, or heavy confrontation, as these approaches can push a client out of treatment. Instead, relapse should be framed as part of the recovery process and used as a learning experience. The counselor should reassess the client's stage of change, identify missing coping skills, and collaboratively revise the treatment plan. The ultimate goal is to help the client re-engage in treatment without feeling defeated.
So for our case study, We have Marissa, who's a 32-year-old Mexican-American mother with 2 young children. She recently completed a 30-day residential program for methamphetamine use and transitioned into outpatient care. 3 days after discharge, she received a call from her CPS worker saying reunification would be delayed due to concerns about her temporary housing. This triggered intense anxiety, shame, and hopelessness. She isolated, skipped group, and eventually relapsed by smoking meth at a former friend's house. She reports immediate regret and has not used since. Her motivation remains high because her reunification is her primary goal. Mm-hmm. To better understand our client's situation, we completed sections of a BPS assessment. Biologically, Marissa has a history of disrupted sleep, appetite suppression, and headaches during active meth use. She also has untreated dental issues. Psychologically, she has a significant trauma history, including childhood neglect, witnessing domestic violence, and intimate partner violence. She struggles with emotional regulation and experiences shame and fear around losing her children. Socially, she faces CPS involvement, unstable housing, financial strain, and limited sober support. These factors all increase her relapse vulnerability.
Mm-hmm. Yeah, so Marissa actually meets criteria for stimulant use disorder, the methamphetamine type. So she does meet criteria to be severe. She meets 9 out of the 11 DSM-5 TR criteria, including unsuccessful attempts to cut down, craving, hazardous use, withdrawal, and continued use despite consequences. Her Z codes reflect environmental stressors that directly impact her relapse risk: unstable housing, family disruption due to CPS involvement, and high emotional intensity with her family system. So to further support our diagnosis and treatment planning, we administered several evidence-based screeners. So Marissa's ACE score, which came back as 6 and indicates significant childhood trauma, which increases her vulnerability for relapse. Her Holmes Race score was 244, places her in the high risk category for moderate stress risk related health and behavioral issues. On her assist, her methamphetamine score was a 35, which indicates high risk use requiring intensive treatment. And her RCQ results place her in the action stage. She is motivated, but she's shaken up by relapse. Her OQ45 score is an 85, which shows significant distress. Based on ASAM scoring, level 2.1, which is intensive outpatient, is the most appropriate care for her.
So using the information gathered from the assessment, diagnosis, and screeners, we have created a treatment plan following the course's treatment planner. Goal number 1 focuses on maintaining abstinence through consistent monitoring and building awareness of relapse triggers. Goal number 2 targets emotional regulation using DBT skills and structured self-care. Goal number 3 addresses environmental stability, housing, and parenting classes that are required for CPS reunification. All goals and objectives are aligned with the addiction treatment planner and are measurable, realistic, and directly tied to her relapse risk. Mm-hmm. So for this client, we chose dialectal behavior therapy, or DBT, because her relapse wasn't random. It was driven by really, really intense emotions and shame and a lot of stress around her CPS and housing situation. When she gets overwhelmed, she goes straight into that emotional spiral where everything feels urgent and out of control. That's exactly the kind of pattern that DBT is designed to help with. Her DSM diagnosis is stimulant use disorder, methamphetamine type, severe. And when you look at her symptoms, they're very tied to emotional dysregulation and impulsive use under stress. So DBT directly targets that by helping clients slow down, regulate their emotions, and tolerate distress without acting on urges. So it fits her clinical picture really well. The specific skill we picked for her is STOP. STOP is stop, take a step back, observe, and proceed mindfully. It's simple, but it gives her a pause button in moments where she normally reacts automatically. For someone who relapsed right after a stressful CPS call, having a skill that interrupts that emotion, impulse, use chain is very huge. There's also a solid research behind this choice. Recent studies show that emotion regulation interventions reduce substance misuse and relapse risk, especially for people with stimulant use disorders. And DBT-based approaches have been shown to help clients stay engaged in treatment and reduce impulsive, emotion-driven behaviors. So clinically, it lines up with her diagnosis, her relapse pattern, and her treatment goals.
Awesome. Thanks. So to close, we have developed 3 questions to further analyze this case and explore clinical decision making, and we're kind of excited to hear your guys' response. These questions help classmates analyze the case study using the relapse model, ASAM criteria, and the chosen treatment modality. So the first question focuses on understanding relapse as a process and not the event. And it says, how does Marissa's relapse reflect the emotional to mental to physical relapse process described in NADAC Module 2? The second question encourages students to apply ASAM scoring to determine the most appropriate level of care, and says which ASAM dimension most strongly influences her recommended level of care and why. And the third question connects to the DBT STOP skill to Marissa's environmental triggers and relapse prevention needs, and says, how does the DBT STOP skill support her treatment goals and reduce relapse risk? Awesome. Okay, and then here is all of our references. We really appreciate you guys, and we can't wait to hear your responses down below.
Thank you.
Thank you so much. Bye.